Honorable Chairperson, distinguished guests, and audience, Assalamu alaikum. I'm Dr. Samia Wahid, specialist oncology. Today, I'm going to present with the topic of optimizing pelvic nodal control in cervical cancer, a prospective comparison of simultaneous integrated boost and sequential boost strategies, assessing therapeutic efficacy and toxicity profile. So cervical cancer, it is the fourth most common female malignancy globally and fourth leading cause of cancer death in women. Approximately 90% of deaths from cervical cancer in low and middle income countries. It is the second most common cancer in Bangladesh. As per hospital-based registry of NICRH, 95.8% of cervical cancer patients presents with inoperable advanced stage. This is a very big barrier to get favorable outcome of cervical cancer. If we see the global data, we see the new incidence of cervical cancer is 6.5% of females in all ages. And it is the 8th most common and 9th most common cause of cancer-related death. But in Asia, the highest incidence is in Asia according to incidence, mortality, and prevalence. Despite vigorous vaccination and screening program, many cases present at advanced stage. Locally advanced cancer often involves positive lymph nodes, and we know nodal positivity means directly related to the higher recurrence risk and poorer prognosis. Therefore, radiotherapy dose escalation is crucial. Furthermore, positive pelvic node frequently lead to para-aortic nodal spread as well as systemic dissemination of the disease, and radiation dose escalation to this involved node is essential for improving regional control. Current standard treatment is the external beam radiotherapy with platinum-based chemotherapy followed by intracavitary radiotherapy. Excellent local control rates have been achieved with the improvement of IGBT, but the pelvic and para-aortic nodal control remains a challenge. So a high dose boost up to 50 to 60 gray on the positive nodes either simultaneously or sequentially, but later that sequentially increases the overall treatment duration, which is known as a non-negligible prognostic factor in pelvic control. The overall treatment time should be 49 days but not exceed 56 days as of OTT has a direct correlation with treatment outcome. The objectives of the study is to compare the efficacy of SIB versus sequential boost, to assess the short-term impact of dose escalation, and to assess the toxicity profile. This is a prospective study occurred in the United Hospital from May 2023 to August 2025. Patients are included into two arms. In arm A, patient receives 50 gray 25 fraction to pelvis and 60 gray 25 fraction to positive lymph nodes. And in arm B, patient receives 50 gray 25 fraction to pelvic and 60 gray 30 fraction to lymph node. So, the histologically proven locally advanced carcinoma cervix patients staging 3C and onwards are included. Clinically positive pelvic and para-aortic lymph node patients with performance status up to 2, who are excluded, who had previous hysterectomy, previous radiotherapy, prior chemotherapy, and FIGO stage 4B. Radiation was planned in supine with bladder protocol, and conformal IMRT VMAT techniques are applied. The RTOG guidelines are followed to control the target volumes, and OAR target includes gross tumor, cervix, uterus, parametria, upper portion of vagina, and the regional lymph nodes. Outcomes are evaluated at the end of RCRT and 3 months after completion of the treatment to assess nodal control, acute toxicity, and dosimetric comparison are also performed. So these are the dose prescriptions, and brachy dose contribution are not analyzed here. Conformity and OR sparing are evaluated as well as parameters aimed to improve dose conformity and reduce high dose spill. So the results. This is the patient characteristics. You see the most of the patients having squamous cell carcinoma and less than 25% patients are adenocarcinoma in both arms. So in arm A, majority of the patients are in stage 3C1 and 11% 3C2 and only 5% in stage 4A. And in arm B, 88% are in stage 3C and 12% in 3C2. Only 1% of the arm B was in ECOG performance status was 2, and rest are in the 0 and 1 performance status. So the maximum diameter of the lymph nodes in arm A, about 54.8% are less than 2 centimeter in diameter, and in arm B, it's 60% nodes are less than 2 centimeter in diameter. The treatment modalities are in arm A, every patient receives Armati or VMAT, and in arm B, that is sequential arm, 9 patients receives Armati and VMAT. The bracket doses are given either 7 gray 3 fraction or 7 gray in 4 fractions, and cisplatin or carboplatin Corcoran chemotherapy based are applied. The physical doses to pelvic target volumes and OAR are evaluated, and we see that if we see the boost PTV here, 100 V90 and V95% are achieved in 100% in both of the arm, and CI index is 0.99 in both arms. And we are very cautious about the OAR when in case of dose escalations are talked. So in OAR, we see the mean doses are achieved within the OAR target, RTOG targets. Acute toxicities are also evaluated. There are no patients having grade 3 toxicities. So the results was mean age is 48 years in arm A and 50 years in arm B. The maximum lymph node diameter in arm A decreased from 2 centimeter to 0.7 centimeter with complete response achieved in 82% of the patients. And in arm B, maximum diameter was 2 centimeter to 0.8 centimeter and 71% achieved complete response. Toxicities are predominantly low, and in arm A, patients achieving slightly greater volumetric reduction in larger nodes, and both strategies are all tolerated. So this is the response rates in pie chart I'm showing here, and this is the dosimetric comparison. This is the sequential in the left, and this is the SIB on the right. We see there's this dose spillage in the sequential arm, and there is a very conformal dose distribution in the SIB arm. So this is the dose volume histogram of the PTB50 and PTB60. On the right, the green one is the 60 gray and the 50 gray. This is the OAR TVHs. So SIB plans demonstrate improved conformity index, reduce high dose pill, shorter duration can improve compliance, and it is very advantageous for the resource limited settings. So this is the prospective design to continue to apply for the overall survival, and it is clinically implemented with the resource limited settings, and larger prospective studies should be validated to evaluate the OS benefit, and longer follow-up need to do to see the late toxicities. These are the references, and I have acknowledged, I'm grateful to my mentors, my teachers, and to the all cervical cancer women whose courage, strength, and grace is the heartbeat of this related research, innovation, and every renewed promise of life. Thank you all.
Thank you, Dr. Samia. So next presentation.